Okay, hello everyone, and thank you for joining me and the rest of us on this educational summary of ITP. My topic is clotting disorders in ITP, which is a slightly complicated issue and requires a lot of considerations compared to already sometimes a difficult situation where ITP can present as management. To start off, I'm just going to show you something which you're all very familiar with, which is the purple color. My wife's favorite color as well. She doesn't have ITP, but she loves purple or anything to do with purple. And I'm sure you've seen the book, My Purple Patch from Anthony Hurd. And what I want to show you is the platelets. Platelets are usually stained purple, which is why it is actually you might want to have chosen the purple color for signifying patient support association. But I just wanted to tell you something which always fascinates me because I have some special interest in etymology or word origins, and is the word origin for purpura. It actually comes from a Greek word, porphyra, which is a shellfish, which gives a purple dye. And why this was actually relevant was because if you look at paintings and also pictures, or probably not photographs from many years ago, before photographs was invented, the royal color was purple, and it's because it's special. And to make purple color to paint, you have to probably kill 10,000 odd of this shellfish to get 1 gram. So what does this all mean? It means that people with ITP are special and probably called royal. So just an interesting thing with respect to purple. Now, my talk is on blood clots. So just trying to think what actually happens inside a blood vessel. What it is required is a fast blood flow. The blood has to go very fast. It has to go smoothly. And if you take the example of a pipe, if you got a new pipe, the blood tends to flow very nicely without any turbulence. And the most important nutrient in our body is the blood. The blood should always flow inside the blood vessel. It should never come out. So it should be contained. So the blood flow in the blood vessel is fast, it's smooth, and it's contained. So why we need platelets, as you all know, it's to stop bleeding. So let's look at how we actually stop bleeding. And what I've shown here in this is a cartoon which I tried to teach medical students it, and this is the inner lining of the blood vessel. So we call it endothelium. And there is a gap here because it's caused by an injury. And what happens is this coiled thing here is actually called a von Willebrand factor, named after a man, Eric von Willebrand, who made a diagnosis of a disease called von Willebrand's disease, which is unsurprisingly a bleeding disorder. And what tends to happen is the platelets are flowing in the blood vessel at a very fast speed. And the speed has been compared by a very eminent platelet biologist who's a scientist who looks at platelets 24/7. Yes, such people exist, and they don't look at anything else from platelets. And he said the platelets move at the speed of a racing car, compared to the red cells, which are the other bigger things in the blood vessel, goes at the speed of probably my car, which is not a fancy one anyway. So why did I say about the speed is because if you have an injury of your blood vessel here, the platelets to stop the bleeding has to come here to stop. And how that happens is this von Willebrand factor, which is usually underneath the blood vessel, will come into the blood vessel. It's a bit like an elephant's trunk. It sort of opens up. And the platelets, which is flowing very fast in the blood vessel, get caught by the von Willebrand factor. So this is relevant because the platelets come to the site of bleeding with help from this von Willebrand factor. And what does it do next? It actually changes shape to spread on top of this gap and close the wound. And we call it platelet aggregation, or in simple terms, is the sticking together of the platelets. The next step is that when the platelets change shapes and start sticking together, it becomes quite nice and a good surface for clotting factors to sit on it, which is depicted by these blue shapes. And what happens then is it forms a blood clot, which is actually like a network or a mesh. So if you see a wound, you can see a network, or you'll see like a net when the wound heals, and that's this clot forming. And one of the important things which is relevant to the talk today is that this clot, when it's formed here, should only form in just this area. It shouldn't form there, or it shouldn't grow inside the blood vessel. If it grows inside the blood vessel, it will cause the blood to stop flowing. It should only happen at this site so that the blood can still flow, but it doesn't come out. And how that happens is there are some things which is called anti-clotting factors, which is inside the blood, which will stop it moving away from this clot site. And also there's another thing called fibrinolysis. So what is fibrinolysis? Fibrin means a clot. Fibrinolysis means the breaking down of the clot. So what that does is to make sure the clot is just nice and clean at this site. And you must have heard of a tablet called tranexamic acid, which we tend to give people who's got bleeding. This tranexamic acid stop this thing happening, this fibrinolytic thing happening, so the clot becomes thicker. So the relevance for a patient who takes tranexamic acid is that it will only work if there's bleeding. It will not work if there's no bleeding, because what it does, it stops the fibrinolytic process, which will only happen if someone's bleeding. So you only need to take it if you have bleeding, and it will make the the clot thicker so it doesn't break down. In summary, to stop bleeding, we require two main things. One is the relationship between the platelets and the von Willebrand factor, and the other one is the clotting factors. And because I also spend a lot of time looking at platelets under the microscope and studying how it works, I've got this interesting figure of how it actually does this. This is actually really what happens under a very, very strong microscope called the electron microscope. And it is actually from this book, which is actually 2,000 pages, and it's about platelets. So if anybody wants to know a lot about platelets, you can read this book. I have got a copy, but it's unfortunately remaining very new. I should be opening it a bit more, but anyway. So what happens is the platelets, like I said, is usually this shape. And when it gets activated, like with that von Willebrand factor, it actually spreads. And it makes sense because it tries to close the wound. And what it does is starts putting arms out so it can catch other platelets. And you can see that's happening here. It's catching other platelets. And if you imagine if there was a wound here, it would be closed by the platelets. Quite amazing what it does. So we talked about how we stop bleeding. So what about when will the blood clot? So the blood clots if the movement of the blood is slow or sluggish. If the movement is not smooth, it is thick, the blood is thick. Or if the blood vessel is actually damaged, it can actually start causing blood to clot more if the vessel is damaged in different parts. This is otherwise called the Virchow's triad. The sluggish flow is called stasis. The thick blood is called hypercoagulability. And the problems with the vessel is called vessel wall injury. And he described this is the cause of blood clots nearly 130 years ago. What does this mean for you? What should you be thinking? What does this mean in simple terms? Stasis means if you're not walking enough and your legs, the blood from the leg should always be pumped back up to the heart. If it's not happening, you're at risk of blood clots. If there's something pressing, so sometimes if you have a swelling inside the abdomen, which is pressing on the blood vessel, that also causes the blood to not flow properly. What about vessel wall injury? That's a bit easier because if you have a surgery or if you have a trauma, an injury, it causes injury to the vessel wall. But if you have trauma, it means that if you have injury in different parts of the body, that can cause thrombosis. And the other one is this thing called vasculitis. This is very relevant to ITP because people with vasculitis can have ITP as a complication. Vasculitis basically means inflammation of the blood vessel, which is similar to having injury because the body recognizes inflammation as similar to injury. And the third one is thick blood, which is hypercoagulability, which I'll come to next. Why would somebody have a thick blood? I mentioned about some anti-clotting factors which will stop the blood clot growing, but there are some people, as a hereditary problem, will have low levels of anti-clotting factors. And these are the things which we look for. We can actually test for this to see if it is low or not. There are also other genetic problems which can affect anti-clotting factors. One of the very common one is called factor V Leiden. It's called that because it was discovered in Leiden, a very beautiful place just outside Amsterdam. And the other reasons for thick blood is something called lupus anticoagulant, which becomes a part of antiphospholipid syndrome. Once again, this is very relevant for ITP because there are some people who have lupus anticoagulant or antiphospholipid syndrome in combination with ITP, but this is not something which runs in the family. Another one is vasculitis, which I've already mentioned, and there is a test called double-stranded DNA test, which your ITP doctor will be doing to pick this up if they got this lupus, which is a part of the vasculitis, which also causes thick blood. Now, some other things which you may know but may not be linking here is the effect of the thick blood and the vessel wall, which can happen with uncontrolled blood pressure, uncontrolled diabetes, high body mass index, high cholesterol, and cancer. Now, if you look at the first two especially, this is a very common problem. So it is important to actually make sure the blood pressure is checked and the blood sugar is controlled and the cholesterol is controlled and you have a good diet, because it could actually make your blood thicker. And another common thing which we used to use for ITP is idiopathic, which means that we don't know sometimes why the blood is thick. And this we really have to bear in mind when we actually discuss treatments for ITP. I just wanted to tell you a bit more about antiphospholipid syndrome because it's one of the ITP international gentlemen asked about this. So what is antiphospholipid syndrome? This is actually tested for if someone had a previous blood clot, either in the artery or the vein, or if they had problems with pregnancy, which could be miscarriages or preeclampsia and things. If somebody had this before, we tend to do 3 tests, which is called lupus anticoagulant and these 2 other big words called beta-2 cardiolipin and anticardiolipin antibodies. The reason for that is because this condition in combination with ITP is the high risk for blood clots. The important thing about these tests is that we need to do it twice in 12 weeks apart, because if it's just positive once, it could actually disappear. So this is what is antiphospholipid syndrome. It can actually predispose somebody to have blood clots and also have issues with pregnancy. The other common thing which also is important to bear in mind is the use of hormones, which could be for either oral contraceptive pill or hormone replacement therapy. And increasingly, we also see patients who want to change sex, where they might actually want to take hormones. And also, if you want to have a body like Arnold Schwarzenegger, although he doesn't look that fit anymore, people use anabolic steroids, which also can cause blood clots. But with respect to the pill, the thing to remember is that it is more than somebody who doesn't use the pill, but it's not as much as the risk of blood clots from pregnancy. So to tell people not to take the pill is not always as important as, because it could prevent pregnancy, which is also high risk of thrombosis. Now, you all might wonder this question which I put here: can a patient with ITP get blood clots? And there are several studies now, both from Professor Newland's group, Professor Provan's group, and others from Scandinavian countries, which actually shown that yes, people with ITP maybe, not always, but maybe slightly increase risk of blood clots compared to patients without ITP. Then you might wonder, why would a person with a low platelet count, which is supposed to stop bleeding, cause blood clots. And the reason for that is I showed you this von Willebrand factor, which is usually released from the body as a very, very long particles. And if they're not, if there's a lot of them released in some people, it might actually make more platelets stick together than what should happen normally. Now, this is a theory, although we don't know, but remember, a person with low platelets from ITP don't bleed, and one of the reasons for that is because of this lots of this von Willebrand factor. But this is a theory, it has not been proven, although there's some paper from Dr. Cooper who suggested this might be a possibility. What about a TPO-RA? And I'm sorry to use the acronym, which is a thrombopoietin receptor agonist. It is mentioned in the literature that the TPO-RA is associated with blood clots. And I've got all the published data here, and I'm not going to go into detail. Basically, it does tell you the numbers of blood clots. But what I wanted to focus on is here. Patients with history of risk factors for thromboembolism. And if you look here, in all the 3 studies, many patients had risk factors for blood clots, and then they got thrombopoietic receptor agents. So what does that mean? Yes, TPO-RA is associated with 2 to 3 times more blood clots. Is based on not a randomized trial, which is what we always like, but based on registry data. But important thing is that it tends to happen if people have underlying risk factors for blood clots, which could be previous thrombosis, presence of antiphospholipid syndrome, and concomitant medications like the contraceptive pill or hormone replacement therapy. So if you do develop blood clots with any of these ITP or thrombopoietic receptor agents, we give you blood thinners, which are 3 types. One is, maybe you might be familiar with this, is called warfarin, which requires blood monitoring and only comes in 1 type of dose. It can only be given to treat a blood clot. Now, there is a lot of interest in this thing called direct oral anticoagulants, or DOACs, which comes in prevention and treatment doses and no blood monitoring required. And the third one is injections of heparin, which clearly are injections and it's not easy to take, but it also comes in prevention and treatment doses. And we usually give blood thinners in 2 situations. One, when people get blood clots called DVTs, which you all might have heard of, and another situation is atrial fibrillation. And this is a DVT. You can see this is a leg blood vein, and you can see the blood clots happening here. And sometimes these blood clots actually break off and become a pulmonary embolism. And the reason for that is because if you not walk long enough, if you have a tendency to form a blood clot from the family history, and if you also had a surgery or a trauma, it will all come together and cause a blood clot. So this again fits in with that. What about atrial fibrillation? I'm just going to give you a couple of slides on atrial fibrillation. So what happens normally is that our heartbeat starts from this bit here called sinoatrial node. It goes smoothly down this route and spreads onto this lower chamber called the ventricles. In atrial fibrillation, what happens is the heartbeat starts from various parts of the atrium, the upper chamber, so it becomes irregular. And what happens, the blood doesn't really flow down to this chamber and gets pooled here. And as I've told you, that if the blood is pooled or it stasis, it forms blood clot, and the blood clot can be pumped out. Small blood clots can be pumped out and can cause stroke. And the reason I picked up here the issue about atrial fibrillation is because the incidence of atrial fibrillation goes up when you hit 60. I don't know what happens at 60, but something magical happens at 60 and it starts shooting up, especially in men. And my wife would say that everything is bad about men, which might be very true with respect to atrial fibrillation. As you can see, women don't tend to get as much problems as men, which is markedly higher. And the other bad news is that the number of people diagnosed with atrial fibrillation in millions is going up. We are here, and we're going to have double that in about 20, 30 years of time. There's 2 reasons for this. One, that we are good at picking this up. And 2, that people are living longer. So we see a lot more people with it. So someone with ITP who might have reached 50 or 60, there's a possibility that you will be picked up to having atrial fibrillation. And how do we treat? We look at this thing called Chat's vasco. Why I put it here is because if you look here, that it talks about hypertension. So blood pressure, diabetes, and age. So these are very common things which requires attention to. And what is recommended by the experts is that if your number is 1 or more for men and 2 or more for women, you should have blood thinners. And that's very easy. If you look here, someone who is 75 has already got 2. Or someone's got blood pressure and is over the age of 65 has already got 2. So a lot of people might require blood thinners from that point of view. And how does blood thinners help? It certainly helps. This is with the tablet called warfarin from some time ago. And you can see if you take warfarin, the risk of strokes is dramatically decreased. And that's why we try to pick up atrial fibrillation and give them blood thinners. The issue about blood thinners is that if you need to give a person with ITP blood thinner, you have to have a platelet count of 50, which is a number we use in the UK, or 50,000 Europe or rest of the world. But we also know that in ITP, the platelet count required for preventing spontaneous bleeding is 10 to 20. So there may be many of you who do not have, who do not take any treatment. Your platelet count always runs about 20. So the issue is that if you develop an atrial fibrillation, or unfortunately are unlucky to get a deep vein thrombosis or pulmonary embolism, you may need treatment for the ITP to safely take blood thinners because it needs to remain above 50 all the time. And to finish off, I'd just like to give you a couple of slides to protect, think about some things which you can do to protect yourself from clots. One, you should go and see your GP and check your blood pressure, blood sugar, and cholesterol. And if they are high, try and control it as much as possible. Keep a good weight and eat healthy. I try and say this to myself every day. It seems to be just remaining as a reminder, but I will try my best, but it's certainly a good thing to do. Regular exercises and avoid prolonged sitting. Now, this prolonged sitting is becoming a problem increasingly all over the world because we all are married to something called a computer and we just keep sitting for a long time. And also with COVID, it hasn't helped because ideally I would have been in front of you and doing this standing up, but now I'm sitting in my office again, sat down to do this. With respect to ITP, you can actually, we can check for autoimmune disorders to look for vasculitis, which can give us a rough idea about if there is a risk for thrombosis. If a person's got lupus anticoagulant positive or previous clots, if possible, we will consider alternatives to thrombopoietin. If possible, but if there's nothing available, we have to think about that. And if there is people with lupus anticoagulant positive and previous clots, if they go for surgery or rarely in pregnancy, we might have to give blood thinners for that short period when they might have a surgery, or probably a bit longer in pregnancy for 9 to 10 months. In the pre-COVID era, we used to fly a lot. So I just thought I'll mention this because I would like to think about a time after COVID when we might be able to see each other and maybe go and see some nice places. So what should you do? Walk every hour, of course, if it's possible. Stretch your legs and wiggle your toes. Wear loose, comfortable clothing. Drink lots of water. Avoid alcohol on the plane. My patients don't like when I say this, but you know, if you drink a little bit, it might be okay. But the main reason we say to avoid alcohol is because you might go to sleep and you wouldn't do these bits at the top. Now, this just doesn't apply not just to flights, it also applies to prolonged car journeys, which is where the smoking clearly applies. And with that, I finish, and I'll give you my email if people have any questions to ask. And I once again want to thank you all for the opportunity, and thank you for doing what you're doing for the Support Association. Thank you.